broadcasting from Miami. Three doctors confused about daylight savings time. We have tonight Carlos Llumiguano, who's second hanger of the day. Well, his topic tonight is awake craniotomy tumors. And Carlos, could you please explain about yourself and then go into your presentation?
Good afternoon. At this time, we will speak about awake craniotomy protocol for brain gliomas. When sometimes when we have some brain lesions such as tumor, it can be this a glioma or some other kinds of lesions, and we ask about what will be happening with the patients, what will be the good performance for the patient, and what's about the correct management of these kinds of lesions, of these kinds of pathologies in the patient. So what to do in cases of lesions located in or near eloquent areas, such as speech, language, visual centers, or motor or sensory areas. What about the risk of permanent deficits of language, speech, motor or sensory function? So we have a lot of questions about the prognostic papers, prognostic facts for the patient. So we have so many options for management of these kinds of patients.
Oh, you're on the first slides, Carlos. Can you move it up forward, please? There you go. Options, okay.
We wait and see until the tumor causes some neurological deficits, or we can do a biopsy. Then after we know the pathological results, we can do in a radiotherapy or a chemotherapy if it's possible, or we can do it in a surgery. If we decide about the surgery, what kind of surgery is the correct techniques for these patients. Maybe under general anesthesia, or maybe doing an awake surgery. If we're doing an awake surgery, we can do it in one or in more sessions. What about these techniques? So this is in ancient times, awake craniotomy was used for trepanation to treat seizures and remove a variety of pathological conditions, or even to permit escape of evil area. So the awake craniotomy is an old technique. It's just renaissance. In 1920, it was described for Penfield during epilepsy treatment. After that, Penfield and Pasquet described all the protocol about the surgical anesthetic aspects. The awake craniotomy, and these days, is more ensured, is more specifically just for the improvements in anesthesia techniques, for the development in neuroimaging techniques, and the development in neuromonitoring techniques. In awake craniotomy, we must know very well what's about the anatomy of the motor cortex. We need to know where is localized an presentral gyrus and postcentral gyrus, where is the location of the Broca areas or the language areas, such as Wernicke areas. So in 1824, 1828, Paul Broca was the first neurologist who described the function of certain areas of the brain. Especially, he described about the speech area, later denominated as broca areas, when he described some kinds of disturbs or speech after lesioning of the posterior part of the third frontal gyrus. So an awake surgery was described thereafter by Foster, Penfield, Ogeman for the epilepsy surgery. After that, Royling, Effling, and others described a good protocol for the oncological surgery. And then after, so many specialists or neurosurgeons do some descriptions about awake surgery, such as Berger, Hecklund, and then after, around the world, a lot of people who are doing these kinds of surgery. In awake patients in neurosurgery, we can divide it. We can show it in during epilepsy surgery or in oncological surgery, or we can see in deep brain stimulation too. For in other techniques in during carotid artery endarterectomy, pain procedures, and peripheral nerve surgery is when the patient are awake. So the main indication for an awake craniotomy is to operate in or near of eloquent brain areas. We can use in cerebral biopsy. We can test of treatment modalities such as deep brain stimulation, peripheral nerve stimulation, motor cortex stimulation, of spinal cord stimulation. This permits a shorter hospital stay. The principal objectives is an assessment and identification of the functional neurological outcome of patients with lesions in eloquent brain areas, pre- and postoperative assessment of language function in patients in whom surgical resections are included or in close to language areas, detection and assessment of patients at risk of postoperative aphasia, reduce to minimum the functional impairments at 6 weeks post-op. We require for these kinds of surgeries a good team with an experienced neurosurgeon, when an anesthesiologist shaving neuroanesthesia, and a neuropsychologist, and a good surgical nursing team. We need a patient who collaborate, who cooperate, who is trained for cooperation, with a hemodynamic stability, with a secure airway. Patient will be on alert and will use an adequate analgesia and sedation, such as a local anesthesia and a scalp blockade. We need a very good environment with a comfortable lying position, soft cushions, etc., and a good and a normal temperature without noise. So we need to have an excellent communication with the patient. We need to monitoring interpretively, such as on a blood pressure, carbon dioxide with a pulse oximeter, the monitorization of the blood pressure, and a beast monitor. We need to control of the diuresis of patient. We need an adjustable operating room table to ensure the patient comfort. We need to use an correct and an adequate anesthesia techniques for these kinds of surgery, such as local anesthesia, scalp blockade, ensure an adequate sedation and analgesia, maintain communication with the patient, and ensure their comfort is the important key point for these kinds of surgery. During the scalp blockade, we can use a great occipital nerve and a small occipital nerve an auriculotemporal nerve, zygomaticotemporal nerve, supratrochlear nerve, and supraorbital nerve, we can blockade every one of these. We need to know a lot of in detail about certain drugs that we use during these kinds of procedures. For example, in the local anesthesia, we need to know the short and long-acting agents, with or without epinephrine, what is dysfunction, what's about the cardiac toxicity, what's about the seizures generation. We know that the propofol decreases the potential of the seizures. During this kind of anesthesia, locally we use lidocaine and bupivacaine. The intraoperative neuromonitorization, and their objective here is to help to provide basic, advanced, and fast monitoring of certain neurological function at risk during surgical procedures. We need to know change in neurophysiological response should alert the surgical team to make adjustments that can reduce a postoperative deficits. For that, we need a neurosurgeon who believes in neuropsychological monitoring, who understands and knows the limitations of the neuromonitorization, who know the correct monitoring of each surgical type, who understand the causes of signal change, ready to act appropriately. We need an anesthesiologist who be familiar with neurophysiological monitorization, be knowledgeable of anesthetics effects on neuropsychological parameters, we be willing to adjust the anesthetic techniques to accommodate response, we able to identify physiological and treat pharmacological changes, and provide support of blood pressure during surgical. Anesthesiologists who check precision and possible nerve compression, check and increase blood pressure, check anesthetic agents, and can convert to a total TIVA, optimize hemoglobin, use muscle relaxants as shown for the case, optimize the temperature for the patient. Within a neurophysiologist who interpretive neurophysiological experience, who had a knowledge of the type of surgery and anesthesia, ability to differentiate and find solutions to surgical, technical, physiological, and pharmacological changes, who had a good communication with the surgical team, who readily available in the operating room. We need a neuropsychologist who be familiar with the OR, who have a good technical knowledge of neuropsychological tests in pre- and intraoperative conditions, and who have a good communication skills with the patients and surgical team. So we can use an electrical stimulation, who will be seen in an excitatory phenomenon in a sensory motor cortex, in a visual cortex, and in an auditive cortex. And we will demonstrate an inhibitory phenomenon in a language, memory, and a higher cognitive functions. When we give for the patients some electrical stimulation, we can see what is the results, what is the changes neurophysiological. The patient must to answer what to signal to us, what he will see, and after we can interpret the response for the patient during and after the electrical stimulation. During And as interpretive neuromonitorization, we can use an cortical or subcortical stimulation. With this, we can identify the central sulcus and the motor area, such as we see in the left picture, where is the cerebral cortex surface, and then after we are putting, we collocated the strip electrodes in the right side. We can see the subcortical electrical stimulation, where we are stimulated the white matter. In the left part, we can see what's above when we decide, when we localize the central sulcus, and the other side, what is the change that we observe during the abductor stimulation. So, the interpretive neuromonitorization, cortical mapping, the case points, it's a gold standard. It is a real predictor of the functional outcome. This procedure is used to map in the brain by applying a current directly to the cerebral cortex by inducing temporary and localized activation or disruption. Yet cortical mapping varies according to the studies and institutions, because at this time we have so many protocols for these kinds of surgery. An intraoperative cortical mapping under general anesthesia, we can use motor evocative potentials and somatosensory evocative potentials. And awake craniotomy, stimulations of one area of the cerebral cortex, we have a response such as verbal, such as movement or emotions and sensations. During speech testing, we will identify the broadcast area by inducing speech arrest. Identification of other cortical language areas by reading and words comprehension, such as a Wernicke area. We can do it on a data presented to or performed by the patient. In this case, the polyglot patients may be a great challenge for these kinds of monitorization. During language and speech location, language areas are multiple within the craniotomy. The distribution beyond the area of Broca and Wernicke, and they have a mosaic distribution. The size of these kinds of centers is about 1 or 2 quadrat centimeter. In 50% of cases are separated. They are located in parietal, temporal lobe, and in sometimes the frontal cortex. It is important, it's critical, the identification of the language areas. Maybe do it preoperatively with non-invasive techniques such as an PET or functional MRI, but all of these methods or techniques is not an objective and sensible like interpretive neuromonitorization. So, what about the inclusion criteria for these kinds of patients, for patients who will be operated under awake craniotomy? 1. Tumors adjacent to eloquent areas, example, left peninsular tumors. Tumors in a placental gyrus can be monitored either under general anesthesia as well. Recurrent or untreated lesions near or within the supposed language area, such as Broca or Wernicke areas. Age between 15 and 70 years. Be fluent in Spanish or English or the language of the country of the patients, but spoken and comprehension. Mentally oriented, no severe aphasia before surgery. An exclusion criteria absolutely is sleep apnea or obstructive apnea, claustrophobia, and dementia for the patient. And a relative exclusion criteria is epilepsy refractory to a drug treatment, airways to difficult access. The complications for these kinds of surgeries are, in first world, seizure in more than 5–10%, conversion to a general anesthesia in less than 1 or 2%, respiratory depression above 5%, airway obstruction, oxygen saturation decrease, arterial hypertension or hypotension, nausea and vomiting, pulmonary aspiration, air embolism, pain, oversedation, paradoxical effect. So many kinds of complications can we have during this kind of surgery. And the other important thing is the patient dissatisfaction, because feel or need or had sensation to urine, feeling cold, dry lips, itching of the nose, that will be alterate the intraoperative neuromonitorization. So we need some kinds of radiological images before to initiate this kind of surgery. They make studies like an MRI compatible with neuronavigation. Within a MRI studies can be fused with diffuse tensor image on a functional MRI. We doing during the intraoperative neurolinguistic evaluation and pre and postoperative assessment and a formal neurolinguistic test performed once preoperatively and twice postoperatively by the Ashner aphasia test. They have a 5 tests and a handling test to identify and manipulate geometric shapes after a verbal command. Repetition test consists of phenomena, words, and sentence repetition. Writing language test is to read and write. Visual naming test is to name objects, colors, and situations presented visually. Understanding test includes choosing the right item among several others. Use it as a distraction after a spoken or written description. So neurolinguistic evaluation, in each, the subtest errors will be classified as known, minimal, discrete, moderate, or severe according to the use of the Ashner aphasia test. Preoperatively patient information and training. At least 3 days before surgery, patients should be informed in detail about the process of intraoperative monitoring, electrical stimulation, by the responsible for the intraoperative test individually and at the appropriate time. The patient should be familiar with the material used for stimulation and trained to perform the tests. So we need to have an overall assessment. We need to establish a good relationship with the patient, inform the patients about all stages of surgery, control of drugs, special anticonvulsants. Always patients may be a great challenge for these kinds of surgery. What about the patient position? The main objective of a correct patient positioning is to increase the comfort of the patient, to reduce intraoperative stress and anxiety, to allow the correct visualization of present stimulus and comply with the requirements of the surgeon. After positioning the patient and disinfection of the surgical area, a local anesthetic is injected at the site of skin incision. Before supraorbital area, zygomatic arc, and retroauricular area. So during the anesthesia techniques, we have a pre-medication regardless of the type of the anesthesia, prophylaxis of nausea and vomiting, impregnation with anticonvulsant prophylaxis, It also will assess the administration of Madital to decrease intracranial pressure and herniation to prevent secondary damage. And a basic monitorization with arterial line, capnography, nasal canu, monitoring the degree of hypnosis with this. Bladder catheterization given the duration of the surgical procedure and the possibility of using osmotic, diuretic, or mannitol. So, it has evolved over the years. Today there are basically two ways. Totally awake craniotomy, just with local anesthesia associated with conscious sedation, function less than 3, and asleep, awake, asleep craniotomy. General anesthesia with intraoperative wakefulness, commonly referred in the literature as a AAA craniotomy. So, as we can show it before, a local anesthesia and conscious sedation, we have two techniques: nerve trunks blockade and scalp blockade. During the scalp blockade requires a large volumes of anesthetic administration by subcutaneous infiltration. Due to the large volumes of local anesthetic, we must be aware of the toxic dose of the used drugs. During a general anesthesia with intraoperative wakefulness, so as asleep, awake, asleep techniques. So during the first period, asleep period, start with infusion remifentanil and propofol. We need to use local anesthetics too. After, in the second time, during the awake period, we maintain the sedation with remifentanil at 0.025, 0.1 milligram per kilogram per minute. Oxygen by nasal cannula with capnography. We do it during this step. We doing a cortical mapping, subcortical mapping, and we doing an end of lesional resection. After that, we have a third period or a third tab, what's a sleep period, when we restart the propofol and remifentanil administration to the patient. During the intraoperative neuromonitorization for electrical cortical stimulation have two possibilities, such as a monopolar stimulation and bipolar stimulation. All of these, or during these kinds of monitorization, we can do it an electrocorticography. During mapping with monopolar stimulation parameters stimulate 24, 5, 7 with another stimulation, intensity of 216 milliamperes, frequency of 250 Hz, period duration of 0.2 to 1 milliseconds. Advantage is mainly the risk increases is very low, less than 8.8%. Also, you can get electromyography response, so you can measure the amplitude and latency for the response and compare with the previous one. Disadvantage with these types of stimulation is mainly it is that less focal stimulation than with bipolar stimulation. And with this type of stimulation cannot perform the language mapping because the duration of the stimulus is not enough. During the bipolar stimulation mapping, the bipolar stimulation with the interelectrode distance of 5 mm, stimulation involves strains of 5 seconds duration with a starting intensity of 2 milliamperes and increasing at 2 milliamperes. So during this kind of stimulation, we need to see the post-discharge result observed in neighboring regions should not limit to the intensity of stimulation. After stimulating cerebral cortex, patient must be observed to view movements. In the area of language, deficits should be assessed after it has achieved a careful baseline. obtained after performing a test of visually naming objects displayed for more than 1 minute and at 5 seconds intervals. During the bipolar stimulation, an area will be considered eloquent if the patient has movement or has an error of language consistent of at least 3 separate triads. We need to know what's about a mapping threshold, what's about the post-discharge threshold. The main advantage for this kind of stimulation is more focal and can map the language area because the stimuli during 5 to 7 seconds. The major disadvantage of these kinds of stimulation is the risk of seizure is bigger, is about 10 to 25%, having to use on concomitant electrocorticography, induce atonic muscle contraction, making it very difficult to measure and compare the response to previous one. Electrocorticography we use to monitoring brain activity of patients continuously searching for the presence of discharge activity in the absence of clinical signs of seizures, so no convulsive seizures. These kinds of capture we can see that what is we register the data registration during this kind of surgery. This is the number case, number of patient, type of lesion, localization of the lesion, what symptoms had before the surgery, if the patient used or not anti-epileptic drugs during the treatment, in which sites, in which localization we do in the electrostimulation, what is the umbral post discharge, what's about the discharge of mapping, what kind of deficits we are observed during the stimulation, in which gyrus we are doing a stimulation, and what is the seizure discharge that will be observed with the patient. So we have a language test, visual naming test, word generation test, and understanding test sentence. This test should be performed 3 days before and after surgery within 21 days and 1 year after that. So during the visual naming test, patients were asked about the name of draw features following the Boston naming test, a standard test to name visually present objects with well-established rules. This test is a robust activator of the essential and not essential language cortex, especially Broca's area. This test is one of the most used in the mapping of eloquent areas because their failure is one of the most common symptoms of aphasia. Language test, word generation test, is a robust activator of frontal language areas. It also activates the language areas in the frontal lobe. So the answer to name visually presented objects is similar to above, except that the description of the object is visually. Language test. What about the understanding test? Patients are presented with 2 identical phrases at all except for one, or that is replaced by a synonym or a different word. They should listen to this pair of sentences and divide which of the 2 has a literal meaning. This test is a potent activator of the brain regions that involve semantic processing, located near the perisylvian cortex. In a postoperative management, we need a controlled blood pressure, visual, electrolyte, level of consciousness, maintain antibiotics, and both prophylactic convulsants, analgesics. If any of these complications, such as infection, seizures, neurological dysfunction, bleeding, cerebral edema, or intracranial pressure increase, cranial CTs should be performed. From 2008 at 2016, we had a neuropathological controlled tumor resection, radical resection in 84.4%, tumor resection under permanent functional control. Histopathology was covered normal, astrocytoma grade 2, astrocytoma grade 3, oligodendroglioma grade 2, grade 3, glioblastoma 13, DNET, meningioma, and metastasis. Referred to location of injury are frontal, precentral in 20 cases, central in 16 cases, temporal 7, temporoparietal 10, temporooccipital 5. We have not any kinds of complications, and the activity of daily living independent in 6 months after surgery in 70%. We have 58 patients, hospitalization an average of 5 days, 2 patients approximately 7 days, 1 patient 10 days. They have medical complications. So we have some kinds of demonstration of how we're doing these kinds of surgery, where we are working in the operative area. The patient is doing the working task that will be asked to him, and he is very weakness during the surgery. So we need to do some movement that during this period the neuropsychologists have good work, good communication with the patient, and we see the electrocorticography registration during the surgery and do it, and this is our work that we are doing. Thank you very much.
Thank you for this great presentation.
Okay, Carlos, thank you very much. I'm sorry, I was a little slow there, Slaven. Thank you very much for a very excellent presentation. And why don't we start with you, Simon? Do you have any questions of Carlos?
Thank you so much. I'm sorry to be late. I just came in and I was just taken aback by seeing the awake craniotomy. So at the moment, I don't have any questions. I was just very impressed. Thank you so much for that.
Well, I have a quick question, Carlos. What kind of anesthesia do these patients get? They must get something for pain, or the brain has no pain, sensory endings.
So we must know that during an awake craniotomy, we use a local anesthesia.
So local.
Local anesthesia, such as lidocaine or bupivacaine together. Because the lidocaine is very fast pain blockading, but they are using for a shorter time than a bupivacaine. This is for more bigger time. So, and we must know that just the scalp is pain for the patient. The bone is not given any kind of pain, and maybe during the dura opening we can say in some, or we can see in some cases that patients say they feeling some kinds of pain, but it's not an intense pain that will be need to do something for this patient. But in some cases we can use on a sleep craniotomy, when the patient during the first time during the initiation or starting the surgery, the patient is sleeping, is sedated. After when we are finished with the positioning, after we are doing with a craniotomy, when we will start or need to start the monitorization intraoperatively, we awake the patient.
Okay.
Okay. So,
Hold on, Slaven. What methods of stimulation this is Slaven's question. What methods of stimulation do you use in order to determine the functional, so-called eloquent areas of the brain?
So in this, we can use two kinds of stimulation, such as monopolar or bipolar stimulation. The difference of the two is that the monopolar stimulation is in a shorter time, but the seizures generation is very low, so it's about 1.8%. But but it's not very precisely, so it's more widest. And the bipolar stimulation is more accurately, more precisely, but the seizure generation is more bigger. It's about 10 to 28%, and the other things, or the other difference between the mono and the bipolar stimulation is that the language area stimulation, which has to do with by bipolar stimulation.
Mm-hmm. Well, I think this is connected to that question. Another question from Slaven. Do you perform water tests for the testing of the speech areas?
No, we didn't use this kind of test. The water test used it so several years ago, and at this time in some centers were during the carotid endarterectomies, carotid dissection, carotid compression test.
Mm-hmm. Okay.
thank you very much.
Very good. I guess, Simon, you're all set? Okay, Carlos, off to Hungary, looks like.
Yeah.
You're hard to keep track of.
Yeah, I go now to take a travel, because I go to Hungary in the morning, and I must go now to Madrid, and then after I take by plane.
Oh, okay. Well, thank you very much for your time, and have a good trip, and we'll see you soon. We'll see you soon.
Thank you very much.
Very much. Have a nice trip.
Thank you very much. Thank you. Bye bye.
Thank you. Good night.